Hi, everyone. This is Dr. Shirlea North from NorthStar Physical Therapy. And today we are going to be talking about pelvic muscle movers and stabilizer. So, our muscles need to be strong and flexible. And there are certain muscles within our body that are more for what we call global movers or like the big movers. Like big ranges of motion. And then there are other muscles that are movers, but they're maybe fine motor movers. So like within our fingers and hands and toes and feet. They're smaller muscles, but their main job is to move something, move a joint. And then we also have muscles that are stabilizers. And their primary function is to help stabilize that joint. For example, up and down the spine, there are several stabilizing, really deep muscles that are stabilizers. And then also within our pelvis, we have our pelvic floor. So our pelvic floor are like a bowl of muscles. There's the internal muscles as well as the external muscles. They will move a little, but they are confined to the bony part of the pelvis. And so one of their main functions is to support and stabilize the pelvis itself, as well as the help support the organs that are above. So no matter if you have a female versus male pelvis and everything, the muscles are very similar. Okay. So for those that can see, I'm recording a visual, right? We have a more female oriented pelvis. Okay. That's pretty common out there now. And then we also have those with male. And so when we rotate up, we see it's a very similar shape and also has that internal bowl. So for those that say, oh, I'm a male, I don't have a pelvic floor, and you are wrong. Every body has pelvic floor muscles. There's external and internal. The main differences are obviously the ones that more have a vagina has a vaginal opening, and the male oriented model is more narrow. It's on its wide. Okay. There are other subtle little differences, but for the most part, we all are the same. Okay. We actually all start embryologically the same. And so the muscles there are pretty darn similar. I'm just speaking very general here. And so when we talk about pelvic muscle movers versus stabilizers, I'm also looking at all the big muscles that are attached to the pelvis that maybe are technically outside of the pelvic floor, but they absolutely interact with the pelvic floor. When I have a client that has low back pain and a pelvic health symptom like constipation or a urinary issue, like they're often tied hand to hand. When I have somebody that had a hip issue, right, orthopedically, that's a big joint there, but those muscles attach to the pelvis, and guess what's on the other side of it? The pelvic floor. So a lot of times pelvic floor physical therapists also treat orthopedic issues because they go hand in hand. And just because somebody is a pelvic floor physical therapist doesn't mean they don't know how to treat your back. Doesn't mean they don't know how to treat your hip or your knees or your feet or your neck or your shoulder. It is all very connected. So another little anatomy 101 is that bones are connected to other bones by ligaments. Bones are connected to muscles by tendons. And there is a huge network of connective tissue called fascia that layer with muscle fibers and that layer with ligaments and tendons. So, yes, oftentimes, if someone has let's say, a shoulder issue on one side, they may have a low back issue on the other side, and maybe also have a pelvic floor issue going on. And guess what? They're all interconnected because of the connectedness of our soft tissue with fascia, with tendons, with ligaments, and with muscles. Okay. So that is a piece that is huge within pelvic floor physical therapy of the connectedness of our body. So when we talk about pelvic muscle movers, I'm talking about like your glutes, your abdominals, your hip muscles where they abduct or adduct, right? You move your leg side to side. Your hip flexors or your hip extensors, so moving your leg forward and back. The rotators, how you rotate your hip in and how you rotate your hip out. There is actually several deep hip muscles and glute muscles that are intimately connected with the pelvic floor muscles. And that's where I like to show things like within a model that as I am demonstrating maybe an internal exam, I'm also showing somebody a very deep hip rotator that literally lies right on top of or right next to, adjacent to a very deep pelvic floor muscle. So if someone's complaining of like really deep hip pain and it's not the joint because they maybe had an x-ray or MRI or whatever, it's not the joint itself. And they're like, I just have this really nagging deep hip pain. And so whenever I do an internal exam, I can test for that. And I can actually palpate that really deep hip muscle and be like, yeah, that's the pain. That's your hip muscle. What? But you're like inside. Yeah. Because they lie right next to each other. They're literally touching each other. So if one muscle is really tender and tight, then it throws off all the muscle balance within the pelvic floor. Conversely, if there's a pelvic floor muscle that's really tight, binding down a hip muscle, potentially, it could be affecting how your hip moves. As pelvic floor physical therapists, we are huge problem solvers. We try to really find out the contributing factors. Is it coming from these bigger muscles like the glutes, like the low back? Is it coming from your thigh, like your quads or your hamstrings? Because your hamstrings, they attach in the bottom part of your sits bone all the way down to your knee. So if something more on the top attachment of your hamstring is like really tight or tender, or it's a little weak on one side, it's going to throw the balance off all these muscles. Your body has an amazing way of compensating for any weaknesses or compensating for any tightness. And so it does that for a while until it just can't do it anymore. And then we have these symptoms. So when we talk about those pelvic muscle movers, it's those bigger muscles that we think of that we're like working out in the gym and doing our exercises with, right? These pelvic muscle stabilizers are more of those pelvic floor muscles that are more traditionally within like these models that are everything in red. This is what I'm saying. Everything in red on my model is a muscle. So there's the external muscle layer. There's also the internal muscle layer that we can see like that bowl shape. And I show both pelvises that they're very similar. It's just different access points. So for those that have a vagina, we can access the pelvic floor stabilizer muscle, not only vaginally, but also rectally. And then for those who are one access point, we can only do it rectally, and that's fine. And honestly, rectal assessments really do need to be occurring for anybody that has any bowel issues. And then also anybody that has like low back pain or coccyx or tailbone issues, because that's where the pelvic floor muscles attach to. They attach to the sacrum and the coccyx. That's per within their name. So there are these things. For not doing the back half, we're totally missing out so much. So a lot of people think that pelvic floor is just the front, it's just for urination issues. No, it's also the whole back half of our pelvis, and these muscles really help stabilize that. So as pelvic floor physical therapists, we are assessing, when I talk about an external versus internal exam, when I say external, I'm looking at like everything from top to bottom to top of your posture, of your shoulders, of your neck, of your spine, of your hips, of your lower back, of your knees, of your feet. We're trying to do a big global assessment that way, seeing if there's any of that is contributing to maybe a pelvic floor issue. And then when I do a pelvic exam, That's when I'm doing, yes, there's the external genitalia and tissue and muscle layer there. But there's also the internal muscle layer there. I very much help educate and I show and I demonstrate of what we're looking at. So that way, when I do perform that incline, they are better educated, they understand what we're looking at. And then oftentimes when we find something on the outside, so to speak, or we find something on external and we work on that first, it's amazing how that can really affect the internal. There's a muscle imbalance. So now we're correcting that and that helped alleviate that tension in the pelvic floor or and help, yeah, be able to allow the pelvic floor to strengthen and turn on because it wasn't having like tightness and tugging on one direction because of an imbalance. So sometimes we need to go outside in before we go inside. Oftentimes it really does help to not only alleviate symptoms, but also to keep them away. If we only work just at the pelvis, we are missing so much information that help feed into that, that help to contribute to that. Because I lovingly call all of my clients onions. There are several layers to us. And so if we're only looking at one layer, it's not going to really give any long-term effect. It may help symptoms at first, but then it's not really helping to keep those symptoms at bay or to help reduce any further exacerbations of that pelvic floor issue if we're not addressing the contributing factors to that. Contributing factors is a whole separate podcast, and that could be anything from like muscles to nerves to posture to hydration to nutrition to stress management, all that stuff. So for this, we're looking at purely the muscles that are affecting the pelvic floor. So again, those are hip muscles in the front, hip muscles along the inner side, hip muscles on the side of the pelvis, and hip muscles on the back side, like your glutes. We have the low back muscles and the huge fascia and connective tissue there. There are ligaments all throughout that connect bone to bone that can affect that as well. We have our abdominals that are in the front part of our pelvis. They're attached from our sternum and ribs and going down and can attach the top kind of rim of our pelvis as well. There's the diaphragm or the very, very top part of our trunk canister, so to speak, a huge muscle, and it moves so much. It interacts with the pelvic floor off of pressure management. So we're looking at all of these things, how our ribs are moving when we breathe, when we exhale, so that way there isn't this pent up pressure that's just pushing straight down to our pelvic floor muscles, and they're just meant to stabilize. But when you have this big force coming down, and maybe they're not strong, or maybe they're too tight because they're trying to do all the work of everything else, there's going to be a pelvic floor issue. So that's where I say, like, whenever we have a pelvic floor issue, it's not necessarily just at the pelvis. It may be these other contributing factors because, let's say, for example, someone has a urinary or bowel issue and their glutes are weak as heck and they have low back pain. If their glutes are weak and they're not turning on and they're bigger muscle, they're tiny little low back and they're tiny little pelvic floor. Our pelvic floor and a low back are probably trying to compensate for what the glutes weren't doing. Oftentimes we need to help lengthen and relax those little muscles that are doing so much work and try to help strengthen the bigger muscles, the glutes, so that way they can help alleviate that tension. So that way, when we do need to turn on the pelvic floor muscles and low back muscles, they are available to do so because they weren't being overworked. So I hope that helps to make sense with pelvic floor physical therapy. We are looking at pelvic muscle movers and the stabilizer and making sure they're doing what they need to be doing and then working in conjunction and concert with one another. So that way we can help alleviate your symptoms and make a more permanent change to help reduce any of those symptoms coming back. All right, guys. And so until next time.